Thank you for tuning in to Reimbursement Rx second live webinar. Again, I am Alexander Lakowski, a practicing internist in San Francisco with 16 years of business and clinical experience, and I'm the founder of Reimbursement Rx. So, what is Reimbursement Rx? Well, it's the first company of its kind that was founded to help established doctors, graduating residents, or any healthcare professionals to better understand the business of medicine and how the world of medical reimbursement works. Um, there's a lot of problems in healthcare. Over the last few decades, it has become more centralized and very top heavy, where a lot of physicians are simply being employed by hospitals and large organizations. And a lot of times they feel like they have no choice. And it's mostly because they don't understand how the reimbursement scheme actually works. This leads sometimes to low morale and not great satisfaction with workplace. And physicians, again, feel like they have no choice. And it doesn't have to be like that. The truth is that the compensation schemes are very complicated, but we can help you myth and debunk most of it. And you can definitely have a lifestyle where you actually can have it both ways, where you can have a practice that you enjoy, where you can have adequate satisfaction, and that will invariably lead to better patient care. And before we start our main topic here today, there's one central rule, or not even rule, a concept that I want you to understand, and that is that there's a shortage of doctors in this country, and you are actually in control of your own destiny. It means that it's okay for you to negotiate your contract. It's okay for you to ask sometimes very uncomfortable questions, because any physician who is going to advocate for him or herself has a really, really bright future. Today, we are going to be talking about one of our most popular topics for physicians, and that is getting a good contract after your residency or even after you've been in practice for a while. As we mentioned before, there are a few cardinal rules that you should always keep in mind before you sign. We are going to expand quite a bit on that today, and of course, as always, answer any questions you may have in the second part or in the middle of our webinar. It is also important to remember that everyone's situation is different, and it's never a bad idea to consult with your attorney just to have them read over your contract. So what are the rules again? And remember, this is just a shell that we believe is very important for anyone looking for a job as a physician or a healthcare-like professional, for that matter, to understand. We will reveal a few additional rules at the end, so you have to stick around to find out. Here we go. Next slide. Cardinal rule number one. Before signing a contract with an employer, you need to find out where your employer gets patients. It's an easy concept that sometimes gets forgotten. As a physician, what is your most important asset? And no, it's not your echo machine and it's not your colonoscope. Those are good revenue sources. What is your most important asset to you? Actually, is your patients. No patients equals no revenue. So that should be the first question you ask your employer. Hey, how are you going to get me patients? Am I replacing a doctor who's been in practice for years and I'm getting his or her practice? Am I being added onto your institutions in hopes of showing that you have a lot of doctors available, but I have to work on establishing myself? Do you have to uh, advertise specially on my behalf? And if so, what platform are you using for such advertising? And how much is it going to cost? It is okay to ask that because days of paper ads are over and now everyone is looking at the internet. And it reaches a lot of people, but it could also get costly very quickly. Now, this particular rule probably does not apply to all organizations. For instance, if you could be interviewing at a hospital or even a bigger conglomerate such as Kaiser, if they are hiring you, chances are they are not hurting for patients and you are needed and they are probably ready for you to start immediately. One particular caveat here, however, is finding out exactly what patient mix you are going to be responsible for and what payment model your employer is going to follow. The reason for this is that if you're being paid percentage of collections and if you're taking care of lower paying patients through Medicaid, for instance, it is important for you to know that. And it's a good time to ask if all of your future colleagues are in the same boat. This is a good example where the RVU model actually works in your advantage because you get credit for service done and not for service paid. So, what you want to hear to wrap up this rule, what you want to hear is that something that speaks to the health of organization. Something like, we have overflow of patients. There is a long waiting list to see a doctor. We just signed a contract with a new payer, or we just had two doctors retired, etc., etc. You should exercise caution if you hear statements such as, well, we're going to reach out to community to get you patients, or we're going to help you grow your practice, or you will get patients from the hospital or ER or any other indirect answer. All right, cardinal rule number two, you need to find out about how your employer gets paid. Why do you need to know that? Well, since you're going to be the one generating income, it is only fair that you're being given a fair answer as to how this income is going to come back to you. Clearly, in straightforward cases, such as in fee-for-service, PPO and Medicare patients, for example, your organization, small or large, will get direct income stream from the payer and through whatever agreement you have with them, such as RVUs, will pass it on back to you. What you really want to know here is if your organization gets any form of subsidy from your local hospital, county, state, or even federal government. If you're interviewing at a major teaching center with residency programs, please remember that federal government, through Medicare Direct Graduate Medical Education Program, subsidized hospitals for residents. With limited data that we have available, we discovered there was one Michigan hospital that received over $96 million from federal, state, and local health plan sources, all funded by Medicare, to subsidize its 569 residents. It translated to just south of $170,000 per resident. Now, obviously, residents don't sniff anything close to that, and for a good reason. Only because they need to be trained, coached, and pretty much showed everything how to do things properly. Um, However, we understand that the point here we're trying to make is that it's okay for you to ask just how your hospital is distributing any leftover money. If you're going to be teaching residents and getting up in the middle of the night, helping them adjust vent setting, you should be paid for that. More likely than not, your interviewer, if he or she happens to be a doctor, will not know the answer to this question. And if you're lucky enough, you will have piqued your interviewer's curiosity, and they will pass it on to the administrator. The administrator will probably laugh at you and will tell you that you don't know what you're talking about because the hospital is losing money on residents. Right. But if you ask this question, and then your friend, and then your friend's friend, and then everyone who's looking for jobs as physicians, your administrator will actually be forced to look at the numbers and look up the answer. And then it might be your turn to laugh. Remember, and I'm going to say it over and over again, you are the one generating revenue. No one else does. And never take the I don't know answer at face value. Moving on to cardinal rule number three. Find out about the employer's HMO and PPO contracts. Now this is a biggie. This really makes a difference if you're going to be working for a large hospital or a small group. Why? Well, you have a huge difference in compensation rates from PPO carriers, as they still pay fee for service for now. It is no secret that big organizations enjoy bigger contracts from PPO payers. This does not always translate to higher reimbursement to you as a physician because you still have your RVUs, productivity model, or whatever deal you're signing. It does, however, mean that your patients will now who almost all of them now have high deductible PPO, will have to pay a lot for your services. Therefore, it is your responsibility to know what your PPO contract is. And just like before, when we talked about the example of how your organization gets paid, if you ask your interviewer just what your PPO rates are, you will get the answer of, I don't know. Do not accept it at face value and keep on pressing. This is very important for you to know. And due to the fact that you are the one generating revenue, this is a vital topic. Similarly, your group's HMO contracts hold no less of a value for you. Depending upon your specialty, you will be either given capitation for your HMO patients or paid fee for service, or some sort of combination of both. Most HMO plans will also pay your employer some kind of a bonus for certain performance criteria that you have to meet. We strongly believe that it is your right to know what those bonuses are and how they're distributed. In one of our videos, we talked about transparency in healthcare. There should be absolutely no hesitation group from your group's leadership to answer your questions about PPO or HMO contracts. If you feel any pushback, or worse off, if you may feel stupid for asking this, you may want to look elsewhere. But it's not just you, if it's not just you who's asking, but if all of your colleagues are, truth will eventually certainly come out. And finally, cardinal rule number 4. Find out whether or not equal pay means equal work in your employer's organization. This one is a bit more philosophical, but we believe it's just as important. What does equal pay for equal work mean? Exactly that. Are some doctors more important than others? Does your organization value specialists more than primary care doctors, or vice versa? Do doctors at your potential group who are in administration and not seeing patients still get paid the same? These are very uncomfortable questions to ask and make you feel at times that you're buying a car rather than establishing your role in your local medical community. But the point is that you must be able not only to ask this question, but also to get a satisfactory answer. Some groups that are RVU based may have different deals with different specialties or specialists. The amount of money that you get paid per RVU within the same group could differ depending upon your specialty. To that, you need to know that insurance companies and Medicare pay the same rate for the same level of service. And this means if your group admits to paying different rates for RVU, you're being taken advantage of. Well, this is assuming that you're on the lower end of the spectrum here. But more importantly, invariably, if you are part of an organization that treats its physicians differently in financial terms, you are set up for low morale and low long-term satisfaction. This particular rule or situation only applies to large organizations because most smaller private groups will likely simply divide all leftover income amongst its partners. All right, moving on. Those are the 4 cardinal rules to obtaining your first or next contract as a physician. Now, as our first additional rule, we encourage you to find out if your compensation is tied to ancillary income. Ancillary income is a hot ticket item, and most large organizations are cashing in on that. Now, it's important to remember that there are a lot of rules and laws that were put in place that prohibit individual physicians or smaller private practices from getting direct cash flow from things such as radiology, lab, physical therapy services, for example. However, a large hospital or a big multi-specialty group may have a way and or a setup where it can profit from providing such services. So for example, if you're employed by a hospital and you then send your patient for, let's say, an MRI, you're entitled to know if doing so will generate revenue for the hospital. And a little hint here, oh yes, it will. It is certainly okay for you to ask to look at financial statements and see just how this ancillary income is distributed. Again, and this is a common theme that Reimbursement Rx would like to convey upon you. You need not be afraid or feel ashamed to ask for it. At the end of the day, you as a healthcare provider are the only piece in the big healthcare conglomerate scheme who can generate any revenue. And that means you have the right to know. The right to know everything. And moving on, additional rule number 2. If you're applying for a position at a hospital or a hospital-based practice, do not be afraid to ask to be paid for night call or any additional work. This point does not pertain to most primary care doctors or non-procedural specialists, and we put it here though just to emphasize the fact that most hospitals do have the funds to compensate doctors for doing quote-unquote extra work. While night call has become somewhat of a routine and a given and standard practice, it is still beyond normal practices for most people. Now, please don't forget that some support staff, such as nurses, do get paid extra for night and weekend work. Coming back to the point that nothing is going to get done at night if you are not there, you should be able to negotiate some sort of a stipend or a bonus or payment for any off hours work that you perform. And finally, additional rule number 3. Ask your employer about expert witness and deposition fees. This might seem insignificant to some of you, but this point should not be overlooked. At certain times during your career, and it actually happens a lot more often than you think, you might be asked to be either an expert witness or, more commonly, you might be asked to do a deposition. For example, your patient is suing someone else for an injury and you treated the patient for that particular injury, and lawyers from both sides will depose you for about an hour for essentially just reading the chart. Now, you're entitled to name your price for that hour, and most firms will give you a check on the spot. Sounds good, right? Well, yeah, it's good if you are the owner of the practice, but if you're going to be working for someone else, please ask them to specify in the contract that if you are ever deposed, all fees are to be paid directly to you and not to the company. Again, it is your right to get paid for your time, for your services. And if your employer says something like, well, you can't do it during work time, then arrange for a lunchtime meeting, or better yet, do it after hours. Again, the point is that your personal time is extremely valuable. All right, so now I will take some time to look at the questions from the audience. Let me take a look here. Let's see. Right. So Gary wants to know, what is an RVU? Well, it's a good question because most of you are going to be paid by RVUs. It stands for Relative Value Unit, and it's a monetary value that is attached to anything you do. As a medical practitioner or professional, you will see patients, you will do procedure, you will give shots, and anything that you do has a certain value determined by Medicare. And you get paid a certain amount of dollars per value, per unit of work completed. What is that amount? That's a great question too, but it's determined usually by where you are geographically. Now, what you're most interested in here is actually WRVU, which are work RVUs, and that takes into account the overhead. And that's what most organizations will pay you. They will tell you per work RVU, you're going to get X amount of dollars. Again, with any additional questions, we encourage you to always email us or, again, at the end of this webinar, maybe ask more questions. All right, let me see if there's anything else. Not much going on right now, so we're going to move on. Next slide. Thank you for your good questions. And now we're going to be turned to one of our most popular questions that we actually got from before, and it's the topic of medical recruiters. Are they good or are they bad for physicians? We have been talking about how and what you should do in order to help yourself get the best deal in your contract, or at least put you in a position where you understand what is going on with your company's financial. But how do you get there in the first place? Is there some sort of a trick or craft to obtain the first job out? Most likely the answer is no. There's probably no one proven way to ensure that whatever it is you are getting into is going to be smooth and easy. There are, however, a few things for you to be aware of and know so that you have a full picture. Here, we are referring to medical recruiters and the way they practice. Now, chances are most of you, especially if coming out of residency or fellowship, already have something lined up at your institution or at one of its affiliates. But some of you, for family reasons or whatever it may be, need to cross city or state lines. And if you have no connections yet, you may turn to service of a recruiting agency. One of the most important things for you to understand here is that most, if not all, medical recruiters operate on a contingency basis. This means, of course, that if the recruiter you're working with is successful in placing you with an organization uh, of any kind, that organization will pay the agency a lot of money. And by a lot, we mean a lot. Anywhere from $18,000 to over $30,000 per doctor. Now, this may even make you actually feel good about yourself, knowing how much you're worth. But such ecstasy should subside rather quickly. Why? Well, by now, after watching many of our videos and listening to our webinars, you probably know what Reimbursement Rx will tell you. You need to figure out where that money is coming from. Yes, so if a hospital just paid, let's say, $25,000 for the privilege of retaining your services, guess whose pocket is going to come out of? Let me give you a hint. It's not going to be your hospital's or group CEO. These recruiting agencies are no more than simple middlemen and women. They simply take your CV and pass it on to medical groups and hospitals. That is it. It'll be $25,000. Thank you very much. You will never meet your recruiter. They will never get to know you, who you are as a person, and they will never know what your true needs are. And truth be told, vast majority of healthcare organizations, from small groups to big hospitals, do not necessarily want to use recruiters simply because of the cost. But they feel like there is no choice and there's nothing else they can do. So what do you do? Are there better ways of finding great gigs other than working with a recruiter? We believe that yes, there are ways. They may not be better, but they're different. All of us know at least one thing, and that is where we want to be geographically. Whether you just finished your residency in Colorado or you've been practicing in Texas for 20 years, you may have decided that it's time now to move to, let's say, San Diego. And while you can still reach out to your recruiter, we suggest Google. That's right. Type your specialty followed by the city. Look up the name of hospitals, local chapter of American Medical Association, and any specialty or primary care groups that come up on your search. Pick up the phone, call them, and identify yourself as Dr. So-and-so from so-and-so looking to relocate to San Diego. And you will be surprised. First, you will feel liberated, and you'll feel like you have almost completed the whole process, the hardest part of the process. Well, that's not the case really. But second, you will be pleasantly surprised because you will almost never hear a resounding no. If you call the hospital, we suggest that you look for the number of a physician liaison. And if you call a group or any private practice, ask to speak with the person in charge. Remember, when you identify yourself as a doctor, it removes a lot of barriers between the receptionist and desired individual. And please, do not be afraid to tell them the truth. I want to relocate, but I don't want to use a recruiter because I want to save you and me money. Like I said, it will feel extremely liberating. And I can tell you, as an owner of a small private practice, if I get a call like that, and if I'm not looking to expand at the moment, I will at least provide the caller with several names of doctors or groups who I know are looking for people. And now we'll be taking some more questions from the audience. Let me take a look here. Again, Ted wants to know that he is interested in private practice. What is your advice for a physician? Well, like everything we said before, number one, you need to know where you want to be. And number two, you need to know what kind of practice mode you want to be in. Private practice is not dying. Private practice is still out there. You may have to work a little bit harder. It depends on where you're coming out of. If you're just out of training, you probably know a lot of local physicians. I suggest you talk to them and see where there's the greatest need for doctors in your community. Um, you will need to sign contracts with payers. You will need to sign agreement with Medicare, assuming you are in one of the adult specialties. And don't be afraid to take out a loan if you have to. Don't be afraid to advertise yourself and be available. One of the most important things, or the best advice we can give to physicians who are starting out, or even not starting out, if you go into private practice, what separates you from being employed is that you are always you. You need to be available for your patients. By virtue of having a smaller working environment, your patients will get to know you, will get to know your staff. They will appreciate being cared for, and it will result in much greater satisfaction for you and the patient. And again, try to speak with established physicians and get a sense of what's going on in the community. For more direct questions, please don't hesitate to email us or contact us, and we'll be happy to provide any advice. So let's see, is there anything else? No questions at the moment. In conclusion, that actually concludes our webinar. Thank you so much for joining us. I hope you enjoyed this presentation. We discussed and elaborated on the 4 cardinal rules when it comes to signing your next contract, on how to maximize your due reimbursement through ancillary income and pay for call, on the topic of medical recruiters, and hopefully answered some of your questions. For more about the topics we discussed today, and much more about the business of physician compensation, we placed links down below to follow Reimbursement Rx on Facebook, Instagram, and YouTube. And please go to reimbursementrx.org for details and information about our upcoming live seminars. Again, thank you for watching.